Welcome everybody to our ACCS review. In this particular section, we will be covering patient assessment, Glasgow Coma Scale, end of life, neurological monitoring, and diagnostic testing. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures. This program will help you prepare for the adult critical care specialist exam, and I hope you enjoy what I show you. The focus of this slide is to talk about neurologic monitoring with different types of patient conditions. For example, if you have a patient with a neuromuscular disease like Guillain-Barré syndrome or any other type of neuromuscular disease, or if you have a patient who had some kind of head trauma. So if you see a question that comes in like that, you need to be able to figure out what's going on with their breathing. So one of the key points to use in this particular group of patients is looking at vital capacity, tidal volumes, and maximum inspiratory pressures. So like I said, a lot of times patients who come into the emergency room with head trauma, they are breathing fine. You know, they're doing great, no problem at all. But as their brain swells from the trauma, it could impact respirations. So what you really need to do with this particular group, and if you see any question goes on with that, you need to monitor their ventilatory parameters, and you do that by looking at their tidal volumes, the vital capacity, and the maximum inspiratory pressure. It's good to do this in neuromuscular patients. It's also good to do this especially in trauma patients, especially with head trauma, because their condition can change over time. So I just wanted to give you the criteria, what's unacceptable. If someone comes in with a tidal volume less than 5 milliliters per kilogram of ideal body weight, it's time to intubate. If someone comes in with a vital capacity less than 20 milliliters per kilogram, time to intubate. So basically, sometimes the questions will pose that their tidal volume is such and such, and they're 5'8", and they got a tidal volume of 100 milliliters, and is that time to intubate? Absolutely. Or if they might say that the patient's vital capacity is going down, and they might give you a normal value, which like 60 milliliters per kilogram would be a normal value. But when you start getting down to 20 milliliters per kilogram or really small vital capacities, it's time to intubate to protect them. So remember that head trauma gets serial measurements of ventilatory parameters using these functions. So let's talk a little bit about a stroke or a cerebral vascular accident. Basically, blood flow to the brain can be impacted by two ways. It could either be done by an ischemic stroke, which is basically a blood clot, or it could be a hemorrhagic stroke, which is basically an internal bleed. Sometimes they'll use the word hemiparetic, which means basically it'll describe the stroke as either being on the right brain or the left side of the brain. The key point to a stroke is to get an early CAT scan. You really need to get a CAT scan ASAP, because this can improve survivability and could also prevent permanent damage to the brain, and it also could create the treatment plan that you need to do. Remember, if someone has a hemorrhagic stroke, there's no way you're going to be giving them any kind of blood thinners, or you're not going to give them aspirin, or you're not going to give them heparin. But an ischemic stroke, yes, you can. There is a whole host of good medications used for ischemic stroke. So the idea with a hemorrhagic stroke, the treatment plan is to probably get them into surgery ASAP and to somehow keep the blood pressure as low in the brain as they can. Regarding ischemic strokes, you're best off treating that with thrombolytic medications such as alteplase or which is known as TPA, and often this often works very good. And they use this same medication for pulmonary embolisms and cardiovascular disease. So you have to identify what kind of stroke it is. Is it a bleed, or is it an ischemic stroke? And you need to treat it properly. And the key point here is you need to get early CAT scan to determine exactly what's going on with the patient. Part of the care for stroke patients is transferring the patient from one location to another. And a lot of times people with a stroke can aspirate. So you really need to be prepared with maybe pulmonary hygiene in case they aspirate. You also may need to have a ventilator handy in case they deteriorate very quickly. Sometimes they might even do prophylactic antibiotic therapy to prevent pulmonary infection. The problem is these patients can aspirate very quickly and they could end up getting an infection. You have to really also determine their level of consciousness, which could be broken down into wakefulness, alertness, and awareness. And I'm going to get a little bit more in that into the next slide. But just be careful when you transfer the patient from one location to another. You may have to have a ventilator handy. You might have to do a pulmonary toilet, and you might have to do prophylactic antibiotic therapy in this particular segment of patients. I am sure you're familiar with these terms that they use to determine the level of consciousness in a patient. It starts from altered mental status, meaning you could be a little bit dizzy, you're really, you forget where, you forget where you are, you wake up and you're something like that, or you could be clouded, which is a mild form of mental status. Then you go to the hierarchy. You could be confused, more profound, altered mental status. You may not remember what year it is, or you may not, say which is the right president of the United States. Lethargy, that's severe drowsiness of which the patient can be awakened by moderate stimuli. Then you have obtunded, and the patient is slow to awaken by stimuli. Then you have stupor, which is really only responds to vigorous stimuli, and then you go right into a coma. So you should understand the level of consciousness in a patient, and sometimes the questions on the exam can be, if someone says someone's stupor, are you going to try to ventilate? You're going to try to wean them from mechanical ventilation? I don't think so. So these are some of the questions that you should know about, and some of the level, and you got here at the hierarchy from altered mental status to coma, and you should know each and every one, which I'm sure you do. So let's get back to the Glasgow Coma Scale. And the reason you really need to know that is because sometimes they'll tell you a history of a patient, and part of the history, they will give a level of consciousness. Also, they'll give a Glasgow Coma Scale. So, for example, just know the ranges. A Glasgow Coma Scale of anywhere from 3 to 8 is severe. The likelihood of them being a successful extubation, very poor. 9 to 12 is moderate, and 12 to 15 is mild. I'm not going to go over the contents of it. Basically it's eye-opening. It's also verbal response. It's also motor response. The maximum score you could get is 15. And so these are some of the scoring systems that you need to know. And because they'll give you a history of a patient, and they'll mention the level of consciousness, they'll also mention the level Glasgow Coma Scale. They might even throw in what kind of breathing pattern they have, which we're going to get into next. So based upon that, you could better articulate your answer. When you take the exam, there's a great chance that they'll be talking about questions regarding breathing patterns. And one of the most common is Cheyne-Stokes breathing. And you may recognize the breathing pattern on the right, where basically the patient goes from little breaths, deeper breaths, and then they go apneic for anywhere from 30 to 60 seconds, and then they repeat the process. A lot of times this is associated with end of life. Anyone who is, in the process of dying will see that. Also, 25 to 50% of heart failure patients have this type of breathing pattern. It could also happen with ingestional errors like drug overdose, intracranial pressures, head trauma, and so on. So you really need to recognize this breathing pattern. And obviously, if someone has this kind of breathing pattern, you may want to intubate them. So just be aware that this is what it is, and most likely they're going to just tell you it's a gradual increase in rate and depth of respirations, followed by a gradual decrease in rate and depth, followed by periods of apnea. And then you say, I know what that is. So just be familiar with it. Another breathing pattern that you should know about is called Biot's breathing. And the difference between Biot's breathing and chain stroke breathing is that chain stroke is very irregular. It's like, they go from little breaths to deeper breath, back to little breaths to apneic, where Biot's breathing is more consistent. It's basically deep, rapid respirations at a rate of greater than 24. They have really deep breaths often associated with it. The periods of apnea can vary in length. So the difference also between chain stroke and Biot is that the apneic periods could be for 10 seconds. It could be for a minute. It all depends. Typically, it's caused by central nervous disorders such as medulla oblongata damage, the pons damage. It could be caused by stroke. It could be caused by opioid use. It also could be caused by increased intracranial pressures due to herniation. The other type of breathing pattern that you might see is called apneustic. And basically, this is end-of-life grunting. And when you hear this when you see that word, you could think about someone who's really on their way out, and this is the breathing pattern you typically would see in an ICU if you're doing a terminal wean. So you should understand the three different levels. You got, chain strokes, you got Biots, and you got apneustic, and those you should know about and some of the reasons behind it. So let's briefly go over brain death criteria. Basically, brain death, when someone has brain death, they are typically unresponsive. There's an absence of reflexes, and there's a presence of apnea. And basically, unresponsiveness is determined by verbal stimuli and painful stimuli. So that's how they determine whether there's any kind of responsiveness. They also do cranial reflexes, such as ocular reflexes. That's where they put ice cold water in your eardrum. And typically, if you don't have brain death, you will look toward that ear. But if your eyes stay fixed and don't do nothing with ice cold water going in your ear, basically you got some kind of brain death going on. Pharyngeal reflex is a gag reflex. Tracheal reflex is similar to a gag reflex. These are all tests you could do for reflexes. Sometimes, we could do apnea test on mechanical ventilation. I've seen that done. Every hospital has its own criteria for it, and probably about that. And sometimes oxygen is supplied during this process via a nasal cannula down the endotracheal tube, but no kind of ventilatory assistance. So those are some of the brain death criteria. I'm sure you know this, but I just wanted to refresh you so you know more about it. Now we're going to get into the topic of seizures. And you may ask, what exactly is a seizure? I'm sure we all witnessed this. Basically, it's a burst of uncontrolled electrical activity between the neurons that causes temporary muscle tone movements. So basically, there are about 4 different types of seizures. They could be either tonic, atonic, myoclonic, or clonic. And each of them have their own type of presentation. So you should understand how each one is. If you happen to see the word, you'll understand a little bit more about it. But we're going to get a little bit more into that as we go along. So what are the most common causes of seizures? And it could be a variety of things. And a lot of times during the exam, they may be talking about someone's an alcoholic and they're withdrawing and they're displaying signs and symptoms of seizures. So it could be electrolyte imbalance. It could be abnormal glucose levels. My brother is a diabetic, and I've seen him go into his sugars were so low he went into a seizure. I've seen brain infections or injury, drug overdose, electrical shock, even fever conditions can do it, febrile conditions, poisoning, stroke, severe hypertension, and as I mentioned earlier, it could be withdrawal from alcohol or medications. All of these could be common causes of seizures. And during the exam, they're not going to really mention it just the way I did, but they're going to give a situation where someone might be severely hypertensive and they're going to give you values, or they'll give you a story about someone's on alcohol withdrawal and they're having such and such symptoms. What do you think? And that's where you're going to have to go with it. So I want to talk a little bit about the signs and symptoms, and more importantly, you need to know what treats seizures. And the signs and symptoms could be a blackout, it could be confusion, it could be drooling or frothing from the mouth. They could have loss of bladder control, they could go into convulsions, and a lot of time they clench their teeth. A lot of times with these patients, you really need to treat the seizure and more or less keep the patient safe from hurting themselves or hurting anyone else. So a lot of times you have to maintain the airway of these patients by putting in a bite block so they don't bite their tongue off or, do some other damage to the mouth. Also, the treatment option for medications is Dilantin. So just remember the medication for the treatment of seizures, because you might get many choices on the exam, and one will be a cardiovascular drug, the other one will be something for ulcers, and so you got to know that for seizures is Dilantin, and just know the generic name too. So I have one slide on end of life. It's inevitable that some patients will die. It's inevitable that we're all going to die one day. So when you have a patient who's at the end of their life and, you have your family there and you have, your doctors there, you got to look at this from a multidisciplinary care approach. You got to look considering the doctor, you got to consider the nurse, you got to consider the RT, you got to consider the family, and you got to consider social services. When you work as a team, a lot of hospitals have really put this together really well. Don't think of just one individual, think of a team. You have to look at 3 dimensions of death. You have to look at the physical aspect, the emotional aspect, and the spiritual aspect. So you have to sort of cover all of these things. If someone's a spiritual belief, you might want to bring in a priest or a rabbi or whatever your faith, whatever faith you are, bring in a spiritual leader for that. Some patients want palliative care. Palliative care is not really only intended for end-of-life care. A lot of people think of palliative care as, you're on your way out. But actually the focus of palliative care is a focus on minimizing suffering. One of the common questions and terms I've seen with this is, if someone is at the end of life, is it okay to put them in, someone's a DNI, do not intubate, is it okay to put non-invasive ventilation on? And the answer is yes. Non-invasive ventilation will minimize suffering from the shortness of breath. Will it extend their life? I don't know. But the point is this, it's a good choice for someone who's a DNI to actually use in palliative care and in hospice care, non-invasive ventilation. So we know hospice, more and more patients die in hospice centers or die at home with hospice care. And, this could be a great way for someone to die with dignity. Some people don't want to be surrounded by nurses and doctors when they're dying. They'd rather be with their family. They'd rather be at home. So you got to consider these things. And then, people have incurable diseases and, they have less than 1 year to live. You got to really have a good conversation with them about what their end of life wishes are. Everyone's end of life wishes are different, and you really need to get a good feel for what they want. So now we're on different types of chest x-rays and different types of diagnostic imaging. So some basic things going on during the exam is that they're going to give you scenarios and asking you what kind of x-ray would be best. So for example, an AP, anterior to posterior x-ray, this is the most common x-ray you do in the hospital. It's good for determining the position of an endotracheal tube. It's done on maximal inhalation, and it can also detect a small pneumothorax. So when you think about it, that is the most common x-ray, AP, good for determining position of an endotracheal tube. It's done on maximal inhalation. Sometimes during the test, they might say the patient fully exhales, and then you take a test. Is true or false? And actually, it's false because you actually have to do it on maximum inhalation. A PA, posterior to anterior. This is most often done when standing. This is not what's done in the hospital setting typically. When we're in a critical care unit, no one's going to stand up and you're going to get an x-ray. Then they have a lateral x-ray. A lateral x-ray helps you visualize the lung from a three-dimensional image. It's an AP chest x-ray reveals suppose an AP chest x-ray reveals a round object that looks like infiltrate. But then if you do a lateral x-ray is done, then you can see that this object is actually round, and it could actually be some form of cancerous mass. So remember, those are the three types of x-rays, and remember the AP is the most common one done in the hospital setting. Another type of image that can be done is called the lateral decubitus. And a lateral decubitus is very helpful when you want to detect a pleural effusion. And it can be described as having a concave superior border or interface. So just remember those words, described as having a concave superior border or interface, and it's helpful for detection of pleural effusion. That would be a lateral decubitus. An oblique. An oblique is any diagonal or non-traditional angle. Basically, it's used to increase the three-dimensionality of the lung and can spot internal structures such as masses, blebs, lesions. It's good for looking at cancer structures and so on. And then we have neck x-rays. It can be very helpful, used to determine inflammation of the upper airway. And it's sometimes used to determine malformations in the anatomy sustained from trauma. So these are three different x-ray types that were above what we just showed. Lateral decubitus, pleural effusion, oblique, looking for masses, neck x-rays, looking for malformations of anatomy sustained from trauma. So just remember those. The NBRC loves to trip you up with fancy words. In other words, they want to use words that may throw you off and think there's some kind of pathology going on with it, but it's not. For example, if you see the word bilateral radiolucency, you might think, oh, what the heck's going on with that? That's normal. That's a normal x-ray. How about sharp gastrophonic angles? That's basically normal. That's, your diaphragm, and that's very healthy. How about hemidiaphragms are dome-shaped, right is higher than the left? They'll say, oh, that sounds like some kind of problem. Actually, that's normal because on the right-hand side, you have your liver, so your diaphragm falls a little bit higher. Or they say the trachea is midline. The trachea should be midline. These are all normal chest descriptions. So remember, when you think about x-rays and you see these words, don't get alarmed. That's a normal x-ray. These are very healthy x-rays. So I wanted to show you a normal chest x-ray versus a pneumothorax. And when you look at a pneumothorax versus a normal chest x-ray, it's really obvious what's different. They might also give you an image and they might ask what's going on with this lung, or they could give you some words that describe the situation. For example, if they write visible visceral pleural edge is seen as a very thin, sharp white line, that's an indication of a pneumothorax. Or no lung markings are seen peripheral to the line, that might be a pneumothorax. Peripheral space is radiolucent compared to the adjacent lung. Or they might say lung may be completely collapsed, or mediastinum should not shift away from the pneumothorax unless a tension pneumothorax is present. So these are some of the terms they use, but I really wanted you to look at the x-ray and be able to see the contrast between a normal x-ray and a pneumothorax. Okay, now this image, we got a normal chest x-ray on the left, and then we have a right upper lobe pneumonia image on the right. And you can see the consolidation is limited to the upper right lobe. You could also see that there's some really good consolidation there. And if the consolidation is due to an infection such as streptococcus or something like that, that is called a lobar pneumonia. So I just wanted you to recognize the difference between a normal x-ray and a right upper lobe pneumonia. And if that organism, if that pneumonia is caused by some kind of infection, they call that lobar pneumonia. So this is an example of atelectasis. And obviously, you know, the image on the left is quite different than the image on the right, and the right side happens to be the atelectic side. Some of the terms that you might see with this is pulmonary opacification, air bronchograms with tubular outlines of smaller airways. You have silhouette signs with obliteration of normal clear outlines between the lung fields and the adjacent structures. There's evidence of volume loss. There's crowding of pulmonary vessels. So these are some of the signs that you see with atelectasis and some of the words that go along with the signs. This is an x-ray that describes a pleural effusion. And a pleural effusion is when fluid gathers at the costophrenic angles. So basically, what you do when you see the x-ray, you'll see the concave lines obscuring the costophrenic angle and part of the hemidiaphragm is obliterated. You really can't see it. And fluid pours in there, and that is example of a pleural effusion on an x-ray. This is a very common question on the exam, and they'll give you an x-ray and they'll tell you to interpret it. And you could clearly see that the endotracheal tube is in the right main bronchus. And this is a problem, so you need to withdraw the endotracheal tube and reintubate and get it out. It's probably too deep. That's what the problem is. But it's very easy to see, and they just love giving this question on the exam. This whole section is going to be talking about placement x-rays. And what do I mean by that? I mean that you're going to have a chest tube put in, or you might have a central venous catheter put in, or you could be intubated with an endotracheal tube. So basically, when you have these tubes in these devices, you want to take an x-ray to determine they're in the right place. So I'm going to go over a few different ones. For example, when the endotracheal tube should be 2 to 5 centimeters above the carina, it should be level with the fourth rib or T4. So when you have an endotracheal tube and they don't give you an x-ray and they say it's 5 centimeters above the carina, you know it might be a little bit too high and has to be advanced. So just remember the anatomical markings where it should be. An endotracheal tube should be 2 to 5 centimeters above the carina, level with the fourth rib or T4. Also, placement x-rays are good for determining a herniated cuff. Sometimes you have a cuff that's herniated, and the only way to really do it is get an x-ray, and you can really determine it. Also, when you look at chest tube placement, it should be in the pleural space. So when you do an x-ray and you're doing it from a chest tube placement, it should be in the pleural space. And it all depends on where they actually place the chest tube, but you know it got to be in the pleural space. Central venous catheter placement. The tip should rest in the right atrium or vena cava. The central venous catheter placement should rest in the right atrium or at the vena cava. Pulmonary artery catheter placement. The distal end in the pulmonary artery, not wedged balloon, not inflated, possibly place the tip in the right lower lung field on an x-ray. So basically, if you have a pulmonary artery catheter placement, the distal end in the pulmonary artery, not wedged balloon, not inflated, and properly placed in when the tip is right over the lower lung field. Nasal gastric tube position should be found in the stomach or the small bowel. So, there's no way of knowing this unless you just read the words and you understand where placement x-rays should be. And there'll definitely be questions about, especially about endotracheal tube being in what kind of place it's placed in. So, more information. A type of imaging commonly used in healthcare is called a PET scan. And a PET scan stands for positron emission tomography. And basically, it's like a radioactive isotope that is used to determine the functionality of organs. So basically, it's different than an MRI because it shows function. It also shows movements such as blood flow, cardiac contractions. It also can be helpful in determining the adequacy of blood flow to the heart. It's good for checking brain function and spreading of cancer. It's good for pulmonary single nodules or suspected cancerous mass. It also very good for testing metabolic or biochemical functions of tissues and organs. And basically, it uses a radioactive drug tracer to show both normal and abnormal metabolic activities. And it's often used to detect abnormal metabolism of disease processes such as cancer. So it's really a good test, and you should know a little bit about it. But the key point here, you think about functionality of the organs, or you could also think about metabolic or biochemical functions of tissues in your body. So that's when a PET scan is good. It's really good for cancer. It's also good for looking at the brain function. So we all have heard of ultrasound. And the ultrasound is very handy in echocardiograms. It's good for women who are pregnant who want to see the fetus growth. It's also good for some new information coming out, what is called ventilator-induced diaphragmatic dysfunction, and they could actually determine the thickness of the diaphragm. So basically, an ultrasound is radio waves that creates a visual live moving image of internal organs. It involves no radioactive material and therefore is very safe. It basically broadcasts sound waves that are bounced back off the organ, and then they got those algorithms, computer algorithms, that create an image. It can be used crudely and inexpensively to assess the size of organs and masses. Commonly used from our point of view, from the adult critical care specialist, it is commonly used to determine pleural effusions, and new evidence has been shown that it's being used to determine the thickness of the diaphragm or the atrophy of the diaphragm with patients who are on mechanical ventilation, and they use that for what is commonly called ventilator-induced diaphragmatic dysfunction. as I mentioned in the previous slide, echocardiogram. Basically, this is, again, a sound wave device, and it can be used to examine cardiac function. It actually can assess the blood flow through the heart. It can look at valve functions. It can look at stroke volume. It could also look at ejection fractions. It's also used to determine whether there's adequate blood flow or any kind of blockages in the heart. It does not penetrate the bone, so no blood flow in the brain can be assessed using this device. Because of the skull, it cannot see inside the brain matter. Then you could do the PET scan. If a pleural effusion is suspected, a thoracic ultrasound is the best option. So just remember that if they wanted to do a look at pleural effusion, a thoracic ultrasound is the best option, as I mentioned on the previous slide. So just understand what an echo, more involved with cardiac issues, heart valves, blood flow, ejection fraction, stroke volume. This is where you want to go. So let's talk about the MRI. What do we know? Don't bring oxygen tanks in the area. Also, you need a special fluidic ventilator with no metal parts to work in the MRI. We used to have a dedicated MRI vent in our unit that we could use. It's very useful to detecting masses, lesions, or nodules without the use of radioactive material. It provides a three-dimensional view of anatomy. It's really good for aortic MRI imaging. Basically, this is the ability to look at the entire aorta without using any kind of radiation or contrast. A normal reference range is imperative in the diagnosis and prognosis of aortic disease and the timing of surgical interventions. So one of the key benefits of an MRI is aortic MRI imaging. Don't bring oxygen tanks in there. Have a specialized ventilator. Very good for detecting masses, lesions, and nodules without the use of radioactive material. That's what you need to know about MRIs. Let's talk about a VQ scan, otherwise known as a lung scan. A ventilation perfusion scan is a nuclear medicine scan that uses radioactive material to examine the airflow, which is considered ventilation, and blood flow, which is considered perfusion in the lungs. The whole purpose of this scan is to determine if there's any blood clots in the lungs, which are called pulmonary embolism. Regarding perfusion, perfusion talks about the process in which gas molecules, both oxygen and carbon dioxide, move between the alveolar and the bloodstream. Abnormal is when the blood flow around the alveolar is hindered. Obviously, we know what a pulmonary embolism, which is a clot in the pulmonary vascular. This is a great test to determine whether you happen to have a PE, and it could be critical because it could be life-saving to do this test. Let's talk about the ventilation aspect. The adequacy of gases penetrating all lungs fields is called ventilation. In this case, the patient breathes in a gas tagged with xenon. Xenon shows up on radiographic procedures and can be seen penetrating all different segments of the lung. So if someone's lungs are clear and you have no blockage, the xenon gas will penetrate everywhere. Dark areas of the lung indicate the absence of ventilation in that area, which means that you got some kind of clot or some kind of problem. If you see dark areas, that is not a good sign, because the xenon should penetrate all areas of the lung. So a VQ scan is great to be done when you are suspecting a pulmonary embolism. Some of the signs and symptoms of a pulmonary embolism is dyspnea, chest pain. It could be tachycardia. It could be a pleural effusion. So these are all the different cases where you want to get a VQ scan. And remember, they use xenon gas, and that's how they determine whether you have proper ventilation. I just wanted to show you what an image looks like when you do a VQ scan. And remember, the dark areas show areas of no penetration. So you could clearly see there's some form of pulmonary embolism going here, and they need to treat that with clot busters because there's you see all these dark areas. So it's a really good scan for determining pulmonary embolism. So I just wanted to go over some indices of respiratory physiology and mechanics. Regarding oxygenation, one of the best tests to do is to get a blood gas, and you get an arterial PaO2. You also could measure SpO2, which is done by pulse oximetry. Then you could do a SaO2, which is done by hexometry. Also, you could look for the presence of cyanosis. You should understand a little bit about the PF ratio, which is your PaO2 divided by FiO2. And basically, as an example, if you have a PaO2 of 200 and you're on 40% oxygen, which is 0.4, not 40, your PaO2 is 500, which is, you're really good. What is ARDS? ARDS has a PF ratio of 200 to 300. Anything under 200 is ARDS. Anything above 200 to 300 could be considered acute lung injury, or sometimes they call that mild ARDS. And the PaO2, the alveolar oxygen tension, I have the equation here, but I didn't see any questions on the test for us to calculate that. But you should understand about the PF ratio. You should know the difference between pulse oximetry and hemometry. And so these are some of the things you got to know. So let's talk about work of breathing. When you're on mechanical ventilation, it takes a certain effort from the patient to breathe. And when you think about work of breathing, it's measured in a term called joules per liter. A normal work of breathing is 0.3 to 0.7 joules per liter. Anything above 0.7 is considered high and indicates an excessive work of breathing. So what kind of conditions will increase your work of breathing? Larger spontaneous tidal volumes, increased respiratory rate. If you have a restrictive lung disease and you have decreased compliance, it takes harder to take a breath. If you have asthma, due to all the resistance, it's harder. Fixed upper airway obstruction is another example where your work of breathing could be higher. Sarcoidosis, ARDS. Now, what can you do to remedy work of breathing? Heliox. Heliox decreases the work of breathing. That is our last slide for this presentation, and we are going to be doing this. We're going to be following up with some new stuff on our next presentation. I want to thank you for joining this presentation, and I have some listings of some good references that you could use for studying this test. Obviously, Kettering and Lindsay Jones are really good sources, as well as my partner, Albert Ure. He has a very comprehensive respiratory therapy exam preparation guide. So hopefully you do very well during the exam.